So CRRT, or continuous renal replacement therapy, is sometimes used in the hospital if a patient has an acute decline in renal function, particularly those who are too hemodynamically unstable to tolerate normal or standard hemodialysis. So it's also used sometimes with medication toxicities that have like a high volume of distribution, tissue binding, plasma binding, and then also a longer half-life. Or if a medication has some sort of redistribution potential, like with lithium or methotrexate. So drug dosing and dialysis can be a little complicated sometimes, because sometimes dialysis will remove the drug and then redosing, you'll have to do that accordingly, or sometimes the medication is just like not removed at all by dialysis, and that can result in drug toxicity. So medications that are not really removed by dialysis are medications that have a high molecular weight, maybe something like filgrastim, or they have a high protein binding, so it's bound to protein in the plasma, so you can't really rip it out. So something like phenytoin, or medications that have a high volume of distribution. Volume of distribution is like a pharmacokinetics term that we use to kind of explain, like, is the drug going to reside in the plasma or the tissue? Is it? This can also relate to lipophilicity as well. So with dialysis, some examples of things that are pulled out are something like vitamins like B and C. That's why we supplement patients on dialysis with that. And then some medications that just are not pulled out are like colchicine. So colchicine is particularly like deadly in toxicity because treatment of that is largely like supportive. Like you can't remove it by dialysis. So colchicine is used for the acute treatment of gout. In a review of 150 patients with colchicine overdose ingestions, at the dose of 0.8 milligrams per kilogram resulted in 100% mortality. Some medications are partially removed by dialysis. So these are the patients that I pay a particular attention to, because I see a lot of prescriptions come through that are just improperly dosed for their creatinine clearance or their stage of kidney disease. So this can be bad because it can either be therapeutic failure or extreme toxicity and death. So I did mention a patient on my page who got baclofen that was basically dosed wrong, and I caught it and I put in a note, and then it just wiped out of the system because we changed the manufacturer, and then we had to re-verify it, and another pharmacist didn't catch it. So the medication was adjusted, like the frequency was adjusted down, but it wasn't adjusted down enough, and this patient ended up going to the hospital for 5 days with baclofen toxicity and hallucinations. So it's very important to pay attention to this. I will say that rosuvastatin is a little interesting, and I believe that there's enough literature with recommendations of how to dose adjust it. It's interesting because it's a hydrophilic statin, and then it's also not heavily renally cleared, but it also exhibits high protein binding. So I thought that was an interesting intervention.